Hello students, today we are going to talk about a very important aspect of medical teaching. That's the general physical examination. You know, this is an art which was sort of a practice for last 2 to 3 centuries. The diagnosis was got through the physical examination, a thorough history and few lab tests. If you see, our clinical diagnosis is based on 3 things. It's like a tripod of a stool. One is the history. In pediatrics, almost about 70% of the data is got from your history and you can make a diagnosis. 20% is physical examination and only 10% is the lab diagnosis. But unfortunately, the present tend to be more and more lab parameters are used to make a diagnosis, and history and physical examination is brought to the backside. So it's very important for you to do a thorough physical examination. As I said, if you see this pic, the major aspect was also physical examination, where we used to have observation, then you have palpation, then you have percussion, then you have auscultation. These were the 4 major things what we used to do in the general physical examination as a part of it. Now what has happened is the importance of physical examination has come down. You can see the size where we rely more on the echo, more on the ultrasound, more on the CT scan, and more on the magnetic resonance. Unfortunately, this is what is happening. But what the patients want is the doctor's touch. Have you asked and talked with them, spent a quality time with them, or you've examined them? You've taken off their cloth, every part of it you have done a physical examination. A doctor's touch can soothe, it can comfort, it can convey caring in a way the words can never be. Despite of the rise of scanners, robots and other new medical technologies, the physician's hand remains one of the medicine's the most valuable medical tool. What is the art of medicine? The art of medicine consists of amusing patient. You need to sort of ask him and amuse him. While the nature cures the disease, that's what our yesteryear's doctors used to say. It's a ritual of affirming connection, commitment, and trust with your patient. A placebo without a placebo was what the patient needs. Medicine is not merely a science of art, but it's an art. Medicine is not merely a science, but it's an art. The character of physician may act more powerfully upon the patient than the drugs what he prescribes. This is what was almost about 2 millennium back, that is Philippus Aurelius Paracelsus said these things. So if you see, this is a very important and very beautiful pic. I think people could have seen it in many of the physicians' room where they hang this pic. This is one of the art which was painted way back in the 18th century, where you can see a physician and a very sick child who's lying on the bed. You can see the physician concern. He is looking, observing the patient. He is looking for the signs what is happening to the patient. Do we see this kind of physician now looking at the patient? Just introspect yourself. You can see that. Now what has happened? It is something like this. Patient has become just an icon, just a sort of a person who lies down in the bed. Everything about the patient is not discussed with the patient. It is discussed in a room or a conference hall where the doctors sit around and discuss his lab reports, his CT scans, his ultrasound and all that, where the real patient is wondering where actual my doctors are there. That's the main thing, link which is missing at that area. So coming to the general physical examination, it should be conducted in a following sequence. You need to look at the attitude and the posture of the patient, because A normal patient, he comes with a good posture and attitude. A child especially, he'll be running around, jumping around. He's so interested in the surrounding in the clinic. But a sick patient, his attitude is of disinterest and he'll be lying down. Most probably mother is carrying him all the time. Whether the patient is restless, whether he's anxious, for example, a child who's hypoxic is anxious and he's restless too. And is he comfortable? He's lying comfortably in the lap of the mother, and is it lying down in the bed? And the level of consciousness is very important, because if you see any physical examination, any diagnosis can be got from three signs. There are three important signs can be able to make all the diagnosis. What are they? Whether the respiratory system is functioning, whether the cardiac system is functioning normally, whether the CNS function. How do we do that? You just have to see whether the child is tachypnic, whether he is conscious, whether he is, what is his perfusion, or what is his blood pressure of the patient. These things will give you a clue. So whether the patient is conscious, whether he is drowsy, whether he is delirious, whether he is stuporous, and he is comatose. These are the various stages of consciousness, which is sort of controlled by the brain. So what are the vital signs? Those are, you need to take the temperature, you need to take the respiration, the rate. Vital signs. What are the important vital signs you need to look at? You need to take the temperature, whether the child is febrile or not, whether he is tachypnic or not, by counting the respiratory rate, checking the pulse rate to see what is the heart rate, and looking at the blood pressure, whether the perfusion is right or wrong. So these are the things you need to look at. So coming to the temperature, it is measured in the axilla in infants and small children. You need to take the temperature at the axilla. Older children, oral temperature can be measured. The rectal temperature is only measured in malnourished children, where you need to have a low reading temperature, or in a very ill child in the pediatric intensive care unit, where you need to sort of monitor the core temperature and the outside temperature, where the difference of it, which is more than 3 to 4 degrees, indicates that there is some amount of shock which is taking. And always the core temperature, that is the rectal temperature, is more than the oral temperature. The normal temperature range is between 97.7 to 99.5 degrees at various times of the day. So infections anywhere in the body, whether it's bacterial, whether it's viral, whether it's fungal, whether it's protozoal, will increase the temperature. Remember, most commonly there are three causes for increase in temperature. That is, it can be infections, which commonly occurs, or it could be inflammation, or it could be oncological condition. So 98% of the causes comes from these three causes. Tissue injury, like for example trauma, burns, or you have given an injection, infraction which occurs, also can give rise to increase in temperature, because basal metabolic rate increases. Malignancy, leukemias, lymphomas cause increase in temperature. Autoimmune diseases like SLE, juvenile rheumatoid arthritis can give rise to increased temperature, that is inflammation. Other inflammatory conditions like inflammatory bowel disorders, drugs, some of the drugs too can give rise to increased temperature, like amphotericin. Endocrine causes of temperature increase is thyrotoxicosis. Whenever there is increased secretion of thyroxine hormone, there is increasing temperature. They feel very warm. Metabolic causes like gout, uremia, and you also need to think of fictitious type of fever, where Munchausen proxy, what we call, because for example, say a child who doesn't want to go to school, so he can faint a temperature, like for example putting the thermometer in a warm coffee. So he says that I've got temperature, and shows the temperature and tells the thing. These are fictitious type of fever which can occur in children. It's very important for us to know the ritual of temperature. Unfortunately, many a times when I go to the ward and ask the students to measure the temperature, many of them don't know. A simple temperature measurement of the child needs to be done as a routine procedure. We should know, how do we take it? How do we, where do we keep the probe? So about this temperature measurement, you can see this video where a temperature is measured of this child. As I said, temperature can be checked at the axilla in a very small and little older children, but bigger children we prefer axilla to the mouth. And you can see, because nowadays we hardly use the mercury thermometer, we always use digital thermometer in children. So you can see this patient, we keep it for a full minute, but most of these thermometers have a switch where as soon as the final temperature is read, it will bleep so that you know that temperature is taken and you can check it. Coming to the respiration, you need to know what is the rate, because you know tachypnea or bradypnea. Increase in respiration is called as tachypnea and decrease in respiration is called as bradypnea. So you need to know the pattern, because there are different types of pattern which I will show you, and you should also know what is the normal for different ages. Preterm and low birth weight babies have irregular respiration. If you see, they will not have a regular respiration. They'll breathe fast for some time, then for some time they may not breathe, or slowly they breathe. Again, they'll have a fast respiration. And occasionally they can have apnea also. Breathing is abdominal in newborns or infants. It becomes abdominal thoracic in young children, and it becomes thoracic in older children and adolescents. Because if you see, initially the abdomen will go up, then the thorax will go. So this is abdominal thoracic respiration. Whereas when we breathe, it sort of our thorax goes first and then abdominal contraction takes place. Respiratory rate varies in different ages, temperature and also in this. Respiratory rate varies with age, temperature and also in the diseases. Respiratory rate is more in newborns and increase in fever and during acute respiratory illness. Normal respiratory rate up to about 2 months is about 60, between 2 months to 12 months is between 30 to 50, 1 to 5 years is about 25 to 40, and more than 5 years it is between 20 to 30. So unlike adults or adolescents, we don't have a fixed respiratory rate. All of you should know that a smaller the baby or a younger the baby, the respiratory rate is normally little more than the older children. Here you see the different types of abnormal breathing. So all of you know about the chain stroke breathing, where if there is bilateral cerebral hemispheres, especially midbrain and upper pons are involved, you can have this type of fever. That is, if you see here, you can see that then there is a rapid respiratory effort, then there is a sort of a apneic type of thing. Again, they can have a acute respiratory distress like thing. This is called as chain stroke breathing, and it occurs in the bilateral cerebral hemisphere dysfunction in the midbrain and in the upper pons. Then you have a central neurogenic hyperventilation, that is continuously they will be breathing very fast. You can see this continuous very fast respiration, especially when there is cerebral edema or there is low midbrain or upper pons involvement. You can get what is called as a central neurogenic hyperventilation. Then there is what is called as apneustic breathing, that is whenever there is midbrain and lower pons involvement is there, you can. So you can get a breathing, for example, they breathe, then they take a breath which is a prolonged inspiration. Then they have a time during the expiration, then there is a apneic type of thing. So it goes on like this. See, there is apnea, then there is a long respiratory effort, then it comes down, there is an apneic type. This is called as apneustic type of respiration. Then there is what is called as a cluster breathing. Again, here you see they will have rapid breathing for some time, then there is apnea, then again rapid breathing like this, apnea. This is especially in the lower pons and high medulla involvement or the lesions are there, they breathe like that. Then you have ataxic breathing, because like ataxia, you just see a small effort is there, then there is apnea, then suddenly there is a crescendo of breathing which occurs, then there is apnea. Then also you should know about the Kussmaul type of breathing. You know, during diabetic ketoacidosis, they have a acidotic type of breathing which is there, that is also can be there. Now coming to the pulse of a patient, it's very important that we need to know what is the rate. How much is the pulse rate? Again, in pediatric, different age has got a different pulse rate. Then what is the rhythm? There is rhythmatic change which occurs in many types of diseases. Maybe it may be arrhythmia, maybe it may be a block, or it could be due to metabolic problem. They can have a rhythm changes. Then the volume, whether the volume of a cardiac contraction is good, you have a good volume. If it is weak, you have a weak volume. Then character, different type of characters of say for example, you have a collapsing type of pulse which can occur in a PDA, etc. Then you have a radial delay. Between the two radial arteries, you have a delay. When that coarctation of aorta occurs, you can get a radial delay. Then you have again in coarctation, you have a radiofemoral delay. You need to palpate on the same side, radial artery and the femoral artery. You can feel the delay in that. Then palpable peripheral pulse, because in children, this is not a very important finding, whereas adult, this palpable peripheral pulse, because of the thickening of the arteries, because of atherosclerosis, they can have very thick peripheral pulse, they can be fine. So this chart gives you a normal heart rate, that is newborn, the heart rate is between 130 to 150. Between 1 month to 1 year, it's about 110 to 130. Between 1 to 4 years, it's about 100 to 120. Then 4 to 8 years, it's around 90 to 100. And between 8 to 12 years, it's about 80 to 90. Now coming to the variation in heart rate, that is, as I said, they can have bradycardia or they can have tachycardia. Let's see what are the causes for bradycardia. So it can be physiological. For example, in sleep, because during the daytime when you are working, that heart rate may be high, but when we sleep, the basal metabolic rate comes, you are in a resting phase, the heart rate comes down about at least about 10 to 15. Or in the athletes, say for example, we had earlier one Wimbledon champion called Boris Becker from Germany. His heart rate was only about 36 to 40. So athletes have a lower heart rate. Then it could be pathological. What are the causes for pathological decrease in the heart rate? It could be hypoxia, it could be hypothermia, it could be hypothyroidism, it could be heart block, or it could be because of the drugs. For example, beta blockers, digoxin, it decreases the heart rate. Coming to tachycardia, that is increase in the heart rate. It could be because of exertion, because when the oxygenation is needed, heart needs to contract faster. So you have exertion increases the heart rate. Crying babies do have increase in the heart rate, or in any anxiety, the heart rate goes high. In pathological conditions like high output states, like for example anemia, thyrotoxicosis, increase in thyroxine secretion, hypovolemia, need to sort of beat faster to provide the nutrients or the oxygen, hypotension, then you have drugs like atropine increases heart rate, nifedipine increases the heart rate. So this is what it goes. Now coming to how do you examine the pulse. Here if you see, if you want to palpate the carotid pulse, palpating the left carotid artery with the right thumb, because if you are trying to palpate the left carotid, you have to use the right thumb. If you have to palpate the right carotid artery, you need to use the left thumb. In this picture you can see just at the sternocleidomastoid muscle, you palpate the carotid arteries. Here you can feel the pulse of the upper limb, for example brachial. This is what it shows, the just medial to the biceps tendon. You have to put your thumb and palpate and feel for the brachial artery. This is again palpating brachial artery against the lower end of the humerus, because you can also palpate little higher up at the lower end of the humerus for this. Now you can check this, like for example when you have a child who is suspecting, for example you have aortic regurgitation, you have a PDA, large amount of blood is runoff is there. So that time you can get what is called as a collapsing pulse or water hammer pulse, etc. Now coming to the examination of the pulse, that is the collapsing pulse. Many a times you can get this collapsing pulse, usually when there is aortic regurgitation, when there is PDA, when there is other condition where there is an aortic runoff. That's a time when you can get collapsing pulse. This is a condition where you need to check it. That is, you need to raise the arm to feel for the collapsing pulse. You can see he is holding with his right hand here, with his lower forearm, and he is holding the fingers of the thing, and he lifts the hand. So when he feels that there is collapsing type or water hammer type of pulse which occurs. This is, you need to examine the pulse of the lower limb. Basically, two arteries you palpate, that is posterior tibial artery, that is you just check medial malleolus. This posterior tibial artery is behind the medial malleolus. You just palpate with your fore and the middle finger, putting your finger there, you can palpate. And this is the dorsalis pedis artery. You can just feel with the three fingers, that is palpating the dorsalis pedis pulse, that is lateral to external hallucis longus muscle tendon. So here you can use the three fingers to palpate that. Now coming to the examination of how do we do a radiofemoral delay. That is, you palpate the radial artery with your left hand and palpate the femoral artery from your right hand. So when you do that, usually normally what happens is that it will be almost equal, or femoral is felt little earlier than the radial artery. But in a child who has got coarctation of aorta, the femoral artery pulse will be felt later than the radial artery. This is how you can diagnose the coarctation of aorta. It's very important for us to diagnose coarctation as early as possible in the newborn period. So a femoral examination is important in children who have coarctation of aorta. Now let's go through this video where a doctor is examining the pulses of this patient. It's very important. You just see how she does the palpation of this peripheral pulses and to assess what is the rate, rhythm, character, volume of this pulse. Coming to the blood pressure, the definition is pressure exerted by the column of the blood on the arterial wall. That is because when the heart pumps, it puts a pressure. So that pressure on the vessel is what you are measuring as a blood pressure. So usually we use what is called as a sphygmomanometer, that is with the mercury in that, but slowly it is being replaced by more and more accurate non-invasive blood pressure monitoring. Earlier ones, maybe 10-15 years back, this was not very accurate. But nowadays the newer NIBPs are coming, which is quite accurate, and slowly I am seeing that it is being reduced by the NIBP monitors which is available. To get a true BP, then you need to do what is called as an invasive BP monitoring, where we'll put a catheter into the radial artery and measure through the transducer, which gives a continuous monitoring of blood pressure. We measure, as you all know, through the Korsakoff sound in the phase 1 and phase 2, where we differentiate between the systolic and a diastolic BP. There are different ways to record the BP. It is like a palpatory method where we check the systolic BP by increasing the blood pressure to a certain level where the sounds disappears and we allow it to come down, and when it sound appears we take it as a systolic BP, or we use with the auscultatory method. Same way we are putting a stethoscope to check the sounds, and of course what I said, a more and more accurate NIBP monitors, that is non-invasive blood pressure monitors, are available, which may replace a sphygmomanometer in near future. It should be measured in all with the appropriate. Its most important thing is we need to measure this blood pressure with appropriate size, because children come with different size and shape. So you cannot have a 2-month-old baby with the same BP cuff as a 6-year-old baby. So bladder should cover at least 2/3 of the circumference of the upper arm. That is, bladder, when you put it, it should cover the 2/3 of the circumference. The size of the bladder in infant is about 4 to 6 centimeters, and in children it's about 7 to 9 centimeters. So it should be taken in all suspected to have a cardiac, you make a routine ritual. Basically, we did a study to find out how many of my postgraduates take the blood pressure. Unfortunately to say, it is only about 25% of the postgraduates routinely take blood pressure in all patients who are coming to the OPD. But it's very important for us to make sure that all children who have got a cardiac disease should be taken blood pressure, and it should be measured both upper as well as lower limb to exclude any coarctation of aorta. And also in coarctation of aorta, the blood pressure is high in the upper limbs compared to the lower limbs. You know, because from the aorta, the vessels which is going up, there may be a coarctation where the blood pressure is reduced below that area. In a preductal coarctation of aorta, BP is higher when measured in the right side, that is on the left side. In preductal coarctation of aorta, BP is higher when measured on the right side when you compared with the left side, that is preductal, because before the PDA rise, if you have a duct which is coarctated or stenosed, then you have the blood pressure which is more on the right side rather than a left side. Whereas normally coarctation, what happened, most of it is postductal. You have a lower limb BP being lower than the upper limb BP. So this is the way you need to sort of take the blood pressure. You all know, because you need to take at the midpoint acromion and olecranon, 40% of the circumference at the midpoint you need to sort of use, and cuff bladder should be covering at least 80 to 100% of the circumference of the arm, and you need to auscultate at the cubital fossa. If you see this cubital fossa, you need to auscultate. You can put the stet here and hear the sounds which is coming. Coming to the anthropometry, the following measurements should be always measured in the general examination. That is weight in kgs, that will give you whether the child is malnourished, whether he is growing appropriate for, say if you have a chronic disease, what happens is weight, they can go for chronic malnutrition, failure to thrive will be there. Height or length, length less than 2 years, you measure the length, more than that you measure the height. Head circumference up to about 5 years, in centimeters you need to measure. Chest circumference in centimeters. If when the child is born, actually head circumference is more than the chest circumference. At 1 year it equals, and chest circumference increases more than the head circumference after 1 year. But if the child has got a severe failure to thrive, chronic malnutrition, head circumference will remain equal or more than the chest circumference. Mid-arm circumference you take in centimeters between 1 to 5 years of age, and upper segment and lower segment ratio, that is at birth, upper segment lower segment ratio will be 1.7:1. At around 7 years it almost equal to 1:1. Now coming to the head to toe examination, it's very important because we need to not miss any findings in these children. Head growth is very rapid in first year of life, because if you see, the 80 to 90% of the growth of the brain occurs in the first 3 years, and the head circumference reflects the brain growth, and birth it's around 34 to 35 centimeters. Growth of rate of head circumference is very rapid in the first year, that is less than 3 months it increases by about 2 centimeter per month. Between 3 months to 6 months it increases by about 1 centimeter per month, and up to 1 year it increases by about 0.5 centimeter per month. Between 2 years it increases by 2 centimeters, and 3 to 5 years it increases by 1 centimeter. You can imagine how much is the rapid growth of the brain in children. So when you look at a child from head to foot examination, the first part of the body which you need to examine is the head. So you need to see for whether the head size is normal or not. If the head size is normal, not normally grown, then you have microcephaly, or if it's increased, you can have a macrocephaly. That is, when you say microcephaly, if the head circumference is less than 3 standard deviation for the mean for the given age, sex and the gestation, you call it as a microcephaly. There can be two types. One is what is called as a primary microcephaly, which is genetic, chromosomal, or which is a variation is normal, or secondary microcephaly. This is because of some problem or some insult which has happened to the brain in the antenatal period, perinatal period, or postnatal period, and which resulted in deficiency of the brain growth at that age. Then you have macrocephaly. Macrocephaly means head circumference is more than 2 standard deviation above the mean for the sex as well as age. What are the causes? That is soft tissues, like for example, if there is a subgaleal bleed in the periosteum, or because of the bone which is surrounding the brain, that is what we call as a hyperosteosis, like for example, which occurs in rickets, osteopetrosis, thalassemia major, because of the marrow expansion, so it becomes big. Whereas osteopetrosis, because what happens is there is hyperostosis of the bone, which makes it bigger. So, or it could be because of the increase in the size of the brain parenchyma, what we call as a meganencephaly. Like for example, Sotos syndrome. There is a Sotos syndrome or Sotos cerebral gigantism. So, they have increase in the brain parenchymal tissue. Or it could be because of the enlargement of the ventricle. There is increase in the fluids or cerebrospinal fluid in the ventricle, which compresses the thing and the brain grows. It could be obstructive or it could be non-obstructive type of hydrocephalus. Sometimes you find familial cases where they have generation of a large head in them with everything else being normal. In the head, especially in small children less than 1.5 years, you need to look at the fontanelles. Usually at birth, it is about 6 fontanelles are present. That is 1 anterior fontanelle, 1 posterior fontanelle, 2 sphenoid fontanelle, and 2 mastoid fontanelle, which is there. But at birth, usually you can palpate only anterior and a posterior fontanelle. Anterior fontanelle, it is here, you can see here, this is a rhamnoid shape one, or you can see this, it is about 2.5 into 2.5 centimeters, and it closes between anywhere between 9 months to 18 months. Whereas posterior fontanelle, you can see, which is at the back, that is triangular shaped, it is less than 1 centimeters, it closes about 2 to 3 months. So, what are the conditions where we see a large fontanelle? You can see it in rickets, you can see it in hydrocephalus, congenital hypothyroidism, malnutrition, osteogenesis imperfecta, where there is a collagen problem, where they can have multiple fractures which occurs, or it could be having achondroplasia. These are the conditions where you find a large fontanelle. Whereas small fontanelle, because of the closure or early closure of the sutures, you can get what is called as a craniostenostosis, or in a variation of normal also they can have that. Fontanelle, again you can encounter sometime what is called as a bulging fontanelle, because when you palpate the thing, usually it is slightly depressed or it's at the level, but sometimes what happens, you can get a bulging fontanelle which is there in whenever there is raised intracranial tension, that is inside the thing because of the cerebral edema, you can get increased intracranial tension, or there is a bleed, you can get a bulging fontanelle, or there is increased fluid in hydrocephalus, you can get that. Crying child or benign intracranial hypertension, you can get this bulging fontanelle. Sunken fontanelle, because of acute gastroenteritis, when there is hypovolemia, dehydration, the fontanelle get depressed. Now it's a time for us to check for the sutural lines. At birth, the skull is made up of multiple bones. That is, you have frontal bone, you have parietal bone, you have occipital bone, you have temporal bone, all those things. They are not joined together yet, because there is need for the brain to grow, need the space for the brain to grow. So what happens is, that is, it closes over the time. It is not usually palpated after 6 months of age. Early infancy, suture lines are separated and gaps are easily palpated. That is, at birth or in early infancy, you can feel the sutural line. There are different types of sutural lines, that is sagittal This is a frontal suture. This is sagittal suture, that is between the two parietal bones you have a sagittal suture, and between the the parietal bone, between the parietal bone and the occipital bone you get what is called as a lambdoid suture. See, this is the anterior fontanelle, this is here you get posterior fontanelle between this thing. So, this is the frontal suture between the two frontal bones which occurs. Now, you can check whether the size of the brain or the shape of the brain is normal or not. There is different shapes of the brain. So, there is what is called as a cephalic index interpretation. That is, cephalic index is head width, that is parietal bone, between the parietal bones and the anterior posterior length, that is head width divided by the head length into 100. If it is less than 60, it is called as a dolichocephaly. I will come to that later, what is dolichocephaly, and 76 to 80.9 is normal. If there is a cerebral index value of more than 76 and less than 80, it is called as normal. And if it is more than that, then it is called as brachycephaly head. Let us check a different types of head, that is dolichocephaly. What happens, as I said, the sagittal suture, that is, here you can see the sagittal suture between the two parietal bones. This closes early. When this closes early, what happens? The growth occurs in the anterior posterior way. So, what happens is that the width is more, AP diameter is more than the width. Brachycephaly, premature fusion of the coronal sutures. You saw the coronal sutures, this suture lines will be closing early. So, you have brachycephaly, premature fusion of the coronal suture, so transverse diameter is more. Here you can see that transverse diameter is more. Then you have what is called as a pagiocephaly, that is head shape is asymmetrical. There are premature fusion of multiple sutures. Then you have a different, so unilaterally it occurs, because you can see here one side is more and other side is sort of a flattened. You have what is called as a plagiocephaly. Now, in the scalp, it is a time for you to look at different scalp swelling. The different scalp swellings could be a dermoid cyst can be there in the brain, in the scalp. There could be histiocytosis, the bone growth. In histiocytosis you can occur, or it could be because of some growth from the bone, what is called as osteoma, or it could be organized cephalometoma because of the fall, injury, especially cephalotoma is common in neonatal age group post-delivery, or it could be traumatic due to some reason. Now look at the hair, because most of the infants can have what is called as a seborrheic dermatitis of the scalp. It is due to a type of fungal infection. It looks like yellow crusted plaques in the scalp. So it is also called as cradle cap. So this is a child which comes with this crusted plaques on the scalp, which needs treatment with the antifungal shampoo. So you have cranial bossing. Here you can see this cranial bossing. It's a prominence of the central parts of the parietal and frontal bones, because when frontal bones there is bossing, prominence, it is called as frontal bossing. It is seen in rickets, vitamin D deficiency, hydrocephalus, congenital syphilis, thalassemia, Hurler's syndrome, achondroplasia. Different condition can give rise to the frontal bossing. Now it is very important for you to know the difference between what is called as a cephalometoma and caput succedaneum, which you see in the neonatal period. It is cephalometoma, it is subperiosteal collection of the blood. It does not cross the suture line maximum by the day 3, because it may not be visible at the first day. By about 3 days it increases and lasts for about 3 to 6 weeks. Caput succedaneum, it's actually a presenting part of the head post-delivery, that is diffuse soft swelling of the scalp. It crosses the suture lines, it is seen at birth, disappears in about 1 to 2 days. And here if you see, this is the scalp and this is the caput, that is subperiosteal area. Here if you also see This is the cephalohematoma, subperiosteal. And if the bleed here, if it occurs, it's subgaleal hemorrhage. And this is the dura mater and the skull bone, and this is the periosteum. So cephalohematoma, remember, it is a periosteal bleed, whereas caput, it is soft swelling of the scalp which occurs here. This is the caput succitanum. Let us go through this video where this doctor checks the head, eyes and the face of this patient. Look at the doctor. She checks the eyes, she checks the head and she checks the face, because there are so many different parts in the face and in the head which you need to check, which can be an indicator of your diagnosis. Now coming to the face, you should know whether the child has got a myopathic face or not. There are many conditions which causes myopathy. That is, usually it is long drawn, expressionless face due to the muscle weakness, because myopathic conditions have a muscle weakness. So it is like a mask-like faces. There is no smile or something like that. It looks a long drawn face and it is expressionless. Or you see a moon face. That is usually when the child who has got a very prominent cheek, rounded face, usually occurs in Cushing syndrome and prolonged steroid therapy. Or a puffy face, where edema in nephrotic syndrome causes puffy face. Or in hypothyroidism, you can see the periorbital edema here, lips may be swollen and there is puffy pale face can occur in these children who have got nephrotic syndrome. Child can have a coarse face, that is, they can have prominent bloated cheeks, protruding tongue, which occurs in hypothyroidism, mucopolysaccharidosis and gangliosidosis, because Gortrup type of face they will have. They can have hemolytic face, because you all know they have, because of the bone marrow expansion, they can have frontal bossing, depressed nasal bridge, maxillary prominence, malar eminence and protruding malaligned teeth can be there. Or you can check for mongoloid faces. The Down syndrome or trisomy 21 have mongoloid faces. That is, they can have this upslanting of the eyes. Then they can have low set ears. It is below the ears, the top portion below the ears. They can have hypertelorism, that is, intracanthal distance is more than the eyes. Or they have depressed nasal bridge. Here you can see the depressed nasal bridge. See, these are all seen in trisomy 21 or Down syndrome. Now coming to what are the causes for depressed nasal bridge. And sometimes it may be normal in certain people because genetically they have that feature. Or in Down syndrome they can have congenital hypothyroidism, Hurler syndrome, congenital syphilis, they can what is called as the saddle nose, they have chondrodystrophy, they can have late stages of leprosy which hardly we see now, and part of the hemolytic phase is they have depressed nasal bridge. And like for example Oriental race, they have a depressed nasal bridge. Now coming to a deformity, what is called as a micrognathia, that is the growth of the mandible does not occur well. It is seen in Pierre-Robin syndrome where they have micrognathia, glossoptosis, difficulty in breathing because the posterior displacement of the tongue they can have. Sequelae of long-standing juvenile arthritis. What happens is temporomandibular joint gets involved, the growth does not occur. They have Cry-du-Chat syndrome, it is because of the mutation of the gene. They have a high-pitched cat-like cry which is there, that's why they call it as Cry-du-Chat. They have mental retardation, they can have seizures. Then I have Dye-George syndrome, it's a immunological condition where they have primary immunodeficiency also. Or fetal alcohol syndrome where the mother takes alcohol, where the fetus is affected, there also you can get micrognathia. Prognathism, that is a child who has got a protrusion of the mandible where you can Angelman syndrome. These are the children who are what is called as a happy children, smiling all the time. They have mental retardation, they have seizure disorder. Again, it's because the mutation in some of the genes. Acromegaly, a child whose growth hormone increased prematurely. Then you have a fragile X syndrome where the X chromosome is fragile, which is called as fragile X syndrome. They can have this prognathism too. Microphthalmia, that is microphthalmos, that is the eye size is small. It occurs in CME, cytomegalovirus infection. It can occur in rubella, toxoplasma, and golden hour syndrome. Golden hour again is a syndrome where they can have microphthalmia, growth retardation, they are small, they have very fine features, upturning of the nose, microcephaly, mental retardation, developmental delay, golden hour syndrome. Cornea, look at the cornea, whether the child has got megalocornea like in glaucoma or in cloudy cornea. For example, in mucopolysaccharidosis, they can have cloudy cornea. They can have red eyes. It could be because of conjunctivitis, viral infection. Inside, look at the inside margin of the lower lip and inferior conjunctiva. If it is congested, possibly it's a bacteria. Blepharon conjunctivitis could be, or it could be a viral infection. Look whether the eyelids are having ptosis, that is only rim of the upper border of the cornea will be covered by the upper eyelid when the child is looking straight. That is, when you look at straight, what happens? The eyelid, which sort of falls forward, should cover only the upper portion of the cornea. So, but here, if it comes below that, then the child has got ptosis. So, what are the causes for ptosis? It could be congenital ptosis. It is maybe because of the oculomotor palsy. It could be because of the Horner syndrome, myasthenia gravis, Noonan syndrome, or myotonic dystrophy. You can get this condition. Coming to the mongoloid slant, you know, I have already told trisomy 21 because the slant is upwards. You can see this, the eyes slant is upwards. It is from the medial to the lateral side. It's associated sometimes because of races also. Orientals have this mongoloid slant. It could be seen in Down syndrome or Prader-Willi syndrome where the child is obese and have mental retardation in this. This is one more child which has got a anti-mongoloid slant. You can see here, see the slant is downwards from medial to laterally, it is downwards. It is seen in Treacher-Collins syndrome, Noonan syndrome, Apert syndrome, and Edwards syndrome. Edwards syndrome is trisomy 18. Apert syndrome have syndactyly, structural abnormalities they can have congenital heart disease. Turner syndrome, you know, and Noonan syndrome can have cardiac disorders, and Treacher-Collins syndrome can have coloboma, they can have ear abnormalities, they can have micrognathia. All these conditions can be there. Coming to the epicanthic fold, here if you see, it's a crescentic shaped fold, crescentic shaped fold of the skin which sweeps to blend with the upper eyelid, because if you see here it sort of blends with the upper eyelid. It is seen in Down syndrome, and some normal children also you see it, but which disappears by about 1 to 3 months of age. Hypertelorism, it is distance between the medial canthi of two eyes, that is here, medial canthi, you can see this, which is more than the width of each eye. This is the width, this is the medial canthi. This distance is more than the width of each eye. It is seen normally also, but it's seen in Down syndrome and many dysmorphic chromosomal anomalies. We see this. Coming to Bitot spots, long time, when maybe 25 years back, the Bitot spots were very, very common. Vitamin A deficiency was very common. Now government has started the program, what is called vitamin A prophylaxis program, where children get 2 doses of vitamin A, one starting at 9 months. With that, lot of it has disappeared also because the nutritional status of a country has improved. You rarely see this Bitot spots. They are grey, you can see here, they are grey dry area on the temporal side, not on the medial side, temporal side of the eye, conjunctiva. It is seen in vitamin A deficiency. Always important, you need to carry a torch source, torch light source, that is to check for the white reflex or cat's eye reflex. Because normally when you put the light on through the pupil, there is a red flare which is seen, but here it is absent and the pupil appears white, because when you shine you get a red, you check it yourself, but when you put it, when you get white, it is called as a white reflex or white eye cat's eye reflex. It occurs in cataract, it is seen in retinoblastoma, or it is seen in retinopathy of the prematurity, it is there. Now coming to strabismus, because many of the children have strabismus or the squint. It is a non-parallelism of the visual axis, because you see both, there is two eyes and two visual axes we have. It should be same, parallel to each other, but if one side you don't have the parallelism, then you get a squint. Small infants have convergent skin, most of them, because one is because of the depressed nasal bridge, it appears like that. Second is, there is in small children, there is a strong medial rectus contraction, because medial rectus is more stronger than the other muscles which, so it is, they can have slight squint like this. So this child, you can see here, large angle infantile onset estrophia, because estrophia means squint, strabismus it means. Now coming to sun setting sign, you can see here, this is a child who has got a hydrocephalus and there is what is called as a sun setting sign. You can see here, the eyes are pushed down and you can see a large area of conjunctiva which is seen. Eyes are rolled down, iris is covered by the lower eyelids, upper sclera is visible. And usually it could be transient in newborn babies, seen in hydrocephalus, seen in a child who has got kernicterus, what is that hyperbilirubinemia, where it crosses the blood-brain barrier and causes injury to the brain, what's called as a kernicterus. Now you always need to look in children for what is called as a KF ring or Kaiser-Fleischer ring. It is seen in the periphery of the cornea, because if you see periphery of the cornea, you can see this KF ring, what is there. It is usually golden yellow, brownish ring. No space between the ring and the limbus of the cornea, and it is not specific for Wilson's. Though we all say KF ring, you look at the Wilson, but it is not specific for Wilson. It can occur in chronic active hepatitis or primary biliary cirrhosis also. You can get KF ring in the chin. Now coming to the other parts of the eyes, that is, you can look at the lid edema, which occurs when there is fluid, more fluid, that is nephritis, nephrotic syndrome, heart failure, kwashiorkor, severe cough or excessive crying, because they continuously cough, there is because the congestion, you can have lid edema. In hypothyroidism, many of the children who have got hypothyroidism, there is some amount of limb edema. Also, they can be because of chronic allergy, rubbing the thing, they can get lid edema. It could occur in conjunctivitis, or whether the child has got a stye, the infection is there, the stye infection, you can get that. Here you can check the nose, that is, put a torch and see if there is any boil there, any deviated nasal septum is there. Then look at the mouth, look at the teeth, look at the tongue, look at the palate, look at the tonsils, look at the pharynx. These are the areas you need to look at. Then you need to look at the ears also. First look at the external ears and see whether there is hypotelorism, whether it's a low set ears, and look at any congenital abnormalities of the ear lobe. And now it is very important for us to check inside the ear also. External auditory meatus. Look at whether there is any abscess which is occurred. Look at the eardrum to see if there is any inflammation there. Use the otoscope. Every one of you should carry an otoscope to check for any impacted wax, acute otitis media. Nose. Sometimes you can see a small featured nose which occurs in trisomy 21 like Down syndrome, trisomy 18, Apert syndrome. A large nose which can occur a beaked nose which occurs in Sickles syndrome, which is again a mutation, developmental delay, they can have seizures. Then it could be because chromosomal 13q deletion, they can have a large nose, they can have a beaking of the nose in Apert syndrome or progeria. Rudimentary nose, if you have a hollow proencephaly, then you can have a rudimentary nose can occur with that. Coming to the ears, you need to check whether the child has got low set ears. What happens is superior attachment of the pinna, here the superior attachment of the pinna must be at or above the line joining the two inner canthi in a normal children, because if you see here, if you draw a line, it should be 1/3 should be above that. You should have the ear coming up like this. But if it is below that area, then it is called as low set ear. Examine from the front of the head erect, eyes facing forward, because this is the type of examination you need to do. Low set ears are seen in Apert syndrome, Carpenter syndrome, Dijorge syndrome, Noonan syndrome, Potter facies, trisomy 13. These are all, you don't just have to know the name as such, because most of it are congenital anomalies. Most of them have developmental abnormalities. They have facial feature abnormalities, dysmorphic features, and many of them are having seizure disorder. Trisomy 18, Turner syndrome, all this have got a low set ears. And protuberant ears, here you can see it is protuberant, it is comes out like a elfin ears. The normal angle should be 10 degrees with the scalp. See here, this angle is much more than 30 degrees it is. If it should be normally, if you see, there is hardly any angle between the ear and the scalp. But if it is more than 10 degrees, then it is called as a protuberant ear. More than 20, posterior rotation of the pinna can occur. So this is also can occur in many syndromes. Coming to the mouth, you have to look at mandibular hypoplasia, which occurs in Pierre-Robin syndrome. You have seen a pic in earlier slides about Pierre-Robin syndrome. They have a mandibular hypoplasia. They have glossoptosis, that is a large tongue in a small oral cavity. Glossoptosis, tongue is falling back because there is no space there. That's called Pierre-Robin syndrome. Also look at his mouth. See here you can see angular stomatitis which is there, which could be because of riboflavin deficiency, iron deficiency, or they can have raggets in the nose. That is, in congenital syphilis they can get raggets in the nose. And philtrum, you can see the philtrum, because this is the philtrum, the long philtrum they can have, which can occur in Williams syndrome. They have long philtrum, they can have microcephaly, they can have congenital heart disease, or they can have cornelia delians, because here again they have a microcephaly, facial features where the eyebrows meet, thick eyebrows they can have, and philtrum can be small in Cohen syndrome. This again a child who has got a small philtrum, mental retardation, they have seizures, developmental disorders. They can have smooth philtrum like flat, featureless, which occurs in fetal alcohol syndrome. Now it's very important, many a times we do miss sometimes in the newborn period looking at the palate. In a hurry we miss it. So but child may have a soft palate deficiency. So they have normal palate is smooth, curved in all direction, prominent palatal bridge due to poor tongue thrusting of the baby, like for example a child who has got a cerebral palsy, because that tongue thrusting does not occur properly, you can have a prominent palatal ridges which can occur. You can have a cleft palate. See here you can get a cleft palate. You can see this palate is deficient here. It is not joined here. So you can have that. Then you can have bifid uvula. That is in Apert syndrome you can get the uvula which is sort of a bifid. Then you can get painful ulcer in the hard palate, especially in herpes zoster infection, herpangia. You can get painful ulcer on the hard palate. Oral thrush usually caused by the candida infection. Prolonged antibiotic therapy can give rise to this fungal infection. Child who is on steroids, child who has got AIDS, hyperparathyroidism. Or sometime in small children we can mistake it for ingested milk, the cream of the milk, which looks like oral thrush. So you should be careful in diagnosing this children. Now coming to trismus, that was seen earlier where tetanus was very common. You would have a neonatal tetanus, but nowadays it is not there. Rhizus sardonicus was the other name for that. That is, they have clenched jaw or clenched teeth, where as if they are smiling all the time in a same position used to be there. So now it is hardly seen. You can get that in infantile Gaucher's disease. It could be part of the dystonia, temporomandibular joint arthritis, because it is sort of a fix there. You can get that, or in a child who has got encephalitis, sometimes you see this trismus. Coming to the teeth, you say delayed dentition even after about 13 to 16 months the dentition has not occurred. It could be because of the constitutional delay, hypothyroidism, hypopituitarism, rickets, or in severe malnutrition you can get delayed dentition. So it's very important for us to know the dental formula. You know that there could be primary teeth or a milk teeth, or secondary or a permanent teeth is there. So adult, there are 32 permanent teeth, that is 2 incisors upper and lower, 1 canine up and down, premolars 2 and 2, molars 3 and 3. Whereas child has got 20 milk teeth, that is incisors 2 and 2, canine 1 and 1, there is no premolars, and molars are 2 and 2. Sometimes you encounter a child who has got a discolored teeth. It could be because of poor oral hygiene, or in earlier days when tetracycline was routinely used. Now also with the advent of rickettsia, we have started using tetracycline. It could come brownish color. In porphyria, child who has got porphyria, it could be reddish. Iron therapy, blackish, and chalky white in endemic fluorosis, where there is in areas where fluorosis is rampant, they can get a whitish or a chalky white type of teeth which is there. Occasionally we do see this gum hyperplasia. Again, it could be recurrent infection of the gums, what we call as a gingivitis, because of the poor oral hygiene, or it could be dilantin or phenytoin therapy, acute monocytic leukemia. Look at the child, because whenever there is a normal child suddenly starts having, who's not on any drugs, having hyperplasia of the thing, think of acute monocytic leukemia. Or a child who has got scurvy, though vitamin C deficiency is rare now, occasionally we do see this scurvy with the gingival hypertrophy. Coming to the tongue could be microglossia or macroglossia. Macroglossia is more common, that is can occur in a congenital hypothyroidism. Down syndrome, they can have what is called as a scrotal tongue, a different, like how the rugae of the scrotum is there, the tongue also has got rugae. And Beckwith-Weidman syndrome, you get a large tongue. Glycogenosis, Hurler's syndrome, or there can be cystic hygroma of the tongue, or there could be hemangioma of the tongue which appears big. So small tongue is seen in spastic flaccid paralysis, upper or motor neuron type of lesions of the tongue. You can get upper or motor neuron, you can get a small micro tongue. Coating of the tongue, as I said, poor oral hygiene, typhoid fever or uremia, you can get whitish coating of the tongue which is seen. Geographic tongue, it's an autoimmune disease which occurs, goes on for sometimes, appears and disappears like that. You should look for that. This is a child who has got a whitish coating, plus you can see the geographic tongue there. Strawberry tongue, just like how the strawberry fruit is there, if it comes, you should think of 2 diseases commonly which is occurring. That is, one is scarlet fever. Second, as children who are less than 5 years, think of Kawasaki disease. We need to keep it in mind, because if you miss, they can have coronary arthritis. Now coming to another video where we need to check at the neck and the lymph nodes surrounding that. Look at this child, how the doctor examined the neck on the both sides. She goes behind and checks for the submandibular lymph nodes, look for the axillary lymph nodes, the different anterior, posterior axillary lymph nodes and posterior occipital lymph nodes she feels, and she checks at the neck properly, look at the other like axillary lymph nodes, supraclavicular lymph nodes. All this we need to check different areas of the lymph nodes to see if there is any lymphadenopathy. You need to look at the neck. Sometimes you can encounter some patients who have got a short neck. So here you can see that child has got a short neck. Here you can see this neck which is very short. You can see it in Turner syndrome. A female who has got short neck, webbing of the neck, think of Turner syndrome. Noonan syndrome, who have got a congenital heart disease and short neck, webbing, think of Noonan syndrome. Klippel-Feil syndrome, deformity of the scapula. Down syndrome, trisomy 21. Sprengel's deformity of the scapula. Hypothyroidism, Hurler syndrome. All these conditions can have short neck. Coming to the lymphadenopathy, it could be generalized involvement, or it could be localized, or it could be persistent, or it could be significant. So generalized, when we say, it should be more than involvement of two different areas. For example, you have a cervical lymph node, but you can have a femoral one, or it could be having an axillary one. Localized, only one lymph node can be involved. Maybe one large cervical lymph node can be there, like for example tuberculosis. Or persistent, that is lymphadenopathy for more than 3 months. You call it as a persistent lymphadenopathy. Significant, any of the following, that is inguinal, if it is more than 1.5 centimeter, because child is having recurrent fall, recurrent injury, recurrent infection of the leg. So about 1.5 centimeter of inguinal lymph node is normal in children. Or cervical lymph nodes, which is more than about 1 centimeter, because many of the viral fevers does cause generalized lymphadenopathy, which disappears. So you should know what are the areas of lymph nodes you need to check. See here, you can see the occipital lymph node. This is a posterior occipital lymph node. These are retromandibular lymph nodes or posterior auricular lymph nodes. These are the parotid lymph nodes. These are lingual lymph nodes, which is here. Sometimes when you palpate the cheek, you feel that it is not any mass. It could be some draining area below the eyes which drains here. These are submental lymph nodes, superficial lymph nodes, cervical lymph nodes, external jugular vein just next to that, those are there, and occipital lymph nodes which is there. So it's very, very important for us to know which area these lymph nodes are enlarged. So there are, you need to sort of check for the characteristics of what type of lymph node there are. If they are soft, like for example in infection, acute infection or inflammatory condition, you can say. If it is firm, think of systemic lupus erythematosus, or it could be because of the Hodgkin's lymphoma. Hard, malignancy or lymphoma. Stony heart, again malignancy, or it's a metastaticized lymph node. If it is firm, rubbery, think of Hodgkin's lymphoma. It is fluctuant, so it could be suppurative conditions like tuberculosis. Shooty, then you think of a viral one where there is small shooty type of lymph nodes which can be fed. So what are the causes? Most often what we see is in children is viral, usually because of adenovirus, HIV virus, rubella you see it, bacteria like tuberculosis, syphilis or brucellosis, malignancy, lymphoma and leukemias, connective tissue disorders like SLE, juvenile rheumatoid arthritis. Sometimes the drugs like anti-epileptic drug like phenytoin can give rise to generalized lymphadenopathy. Or it could be because of the granulomatous disease like sarcoidosis, amyloidosis, you can get lymph nodes in the children. Now coming down to the chest. Chest is a part of in between the neck and the abdomen. Basically it holds very important organs like lung and the heart and the whole mediastinum. 3 parts of the mediastinum is there. It's a closed cage with heart and lungs within them. So sometimes what are the abnormal finding, what you can find it? Sometimes you get a widely spaced nipple. Here you can see this child, the nipple are widely spaced. That is inter-nipple distance is more than 25% of the chest circumference. Then only you call it as a widely spaced nipple. So this can occur in Turner syndrome and Noonan syndrome. And what is called as a polythalia, that is you have a supranumerary temple, which is also can be associated with cardiovascular disease or urinary abnormalities. If you see, what happens is the breast buds in the antenatal period are a large distinct from down from the kidney to upwards it is there. So it slowly gets reabsorbed. Sometimes a small part of the breast buds remains there, or you can get what is called as a supranumerary nipple or polythalia can be there. It is of not much of a significance, but if it is there, better always look for the CVS or urinary abnormality. Then you can look at the spider nevae. It's a central artery with a multiple radiating blood vessels which are there, which is surrounded by the some sort of a erythematous rash. You can get as a liver failure, you can get this. And you need to look at the what are the chest deformity, whether the chest is properly formed or not. You can get what is called as a pectus carinatum or a pigeon chest, that is the chest is protruding forward. Forward protrusion of the sternum with straightening of the anterior ribs called as pectus carinatum. It is found in rickets. Pectus excavatum, as if it is excavated. It's a funnel-shaped depression of the lower end of the sternum. Here you get funnel-shaped depression, like as if it is excavated. It is called pectus excavatum, which you see in Marfan syndrome, again in rickets. You get barrel-shaped chest, like for example, if you got emphysema, you can get what is called as barrel shape. Sometimes you get a bell-shaped this thing, where it's called Elwin-Swan Cleveland this thing, where they have a mental retardation, they have limb abnormalities, and they can have bell-shaped chest. So this is what is rachitic rosary. Here you see, because of the deficiency of vitamin D, they get what is called as a rachitic rosary. It is because of the defective mineralization of the bone, because of the vitamin D deficiency. It is rounded, because they will ask you what is the difference between a scorbutic rosary and a rickety rosary. The bones here are easily bendable. Primary symptom is usually skeletal deformity, and it is painless. Remember, it is painless. Whereas scorbutic rosary, it's because of the defective collagen formation. It is because of the vitamin C deficiency. It is more angulated. That round this thing, what is more angulated. And bones are easily breakable in vitamin C deficiency. They can be gum bleeding, and it is painful. It is painful, remember, whereas rickety rosary is not painful. It is rounded, here it is angulated. These are the points you need to remember. Sometimes what happens is in a male child, you get enlargement of the breast, usually because of the imbalance between the testosterone and estrogen which occurs, and decrease in the androgenic level sometimes you can get, or estrogen excess. Sometimes what happens in infancy and during the puberty, there is sudden increase in the estrogen level. There are some drugs which can cause this gynecomastia. What are they? Spironolactone, ranitidine, antidepressant can cause increased size of the breast. Chronic diseases like chronic kidney failure, chronic liver failure can cause that. Genetic like Klinefelter syndrome, Kallman syndrome are the ones you can see here. You can see the enlargement of the breast in this male. It is unilateral enlargement in this thing. Now it's a time for another video where the doctor will examine the back, spine and the extremities of the thing. It is very important for us to check for the curvature of the spine when the patient is standing straight. Now you feel the spine. Feel the spine if there is any gibbous, any deformities, meningomyelocele, myelocele, then pilonidal sinus. It's very important for us to check for this. Also come at the front and check for the extremities. Look at the fingers, look at the palm, thenar eminence, look at the angulation, look at whether there is simian crease is there, look at the cubital fossa, look at the lower extremities, look at both the ankle as well as knee joints, look at any wasting of the muscles are there in these children. Now coming to spine, look at scoliosis, that is the lateral curvature of the spine. Here you can see how the lateral curvature of spine is bent, and this is kyphosis, that is forward bending of the spine. Then you have a gibbous. See, in tuberculosis you can get gibbous because of the underlying collapse of the vertebra. Most often it occurs because of tuberculosis. And coming to the fingers, when you see the fingers, see these fingers, these are all joined together. This is actually Apert syndrome. Apert syndrome, you have fingers like this. This is called as syndactyly. 2 or more digits are fused. Clinodactyly, it is because the curvature, here you can see, it can seen in Down syndrome, curved little finger, because what happens is you have 3 phalanx in the thing, because if this becomes hypoplastic, then the curvature of the little finger occurs. It can be also normal variant, but it is seen in trisomy 21. Post-axial or pre-axial polydactyly, if the child has got more than 5 digits, whether it's in the hand or in the feet, it's called as polydactyly. It can be seen in Turner syndrome, it could be Carpenter syndrome, that is there, it could be pre or post-dactyly. Sometimes there can be arachnodactyly. Arachnodactyly means the fingers and toes are abnormally long and very thin, which occurs in Marfan syndrome, hypogonadism or hypopituitarism. You can have. Here you can see this boy has put his finger, that is thumb is almost protuberant, almost to the opposite side. Here with his little finger and thumb, he can encircle his wrist. So this occurs in Marfan syndrome, and you need to look at it. Coming to nails, normally grow at the rate of 2 to 5 millimeter per month in fingers and half the size in the toes. And growth rate is maximum in childhood. As you grow older, it starts coming down. So here you can, this is the cuticle, what we call as a cuticle. This is called lanula, and this is the nail plate. Here you can see this, what is called as a skin which is above that, called eponychium, and this is the nail bed, and this is called hyponychium. So this is the structure of the nail, what you get. So there are some pointers. Abnormality in the nails can give rise to diagnostic marker for some of the diseases. Let's see what are those. What we call as cholinachia. It is a spoon-shaped nail. Here you can see it's like a spoon, depressed like a spoon shape. It is soft, it is brittle, which occurs in iron deficiency anemia. You can get flat nails, what is called as a platinachia. Again, it can occur in chronic iron deficiency anemia. Brittle nail, which can be easily broken, can occur in malnutrition, protein allergy malnutrition. Pitted nails, which can occur in eczema, or it could be in alopecia areata, you can get that. Splinter hemorrhages below the knee, below the nails, you can get splinter hemorrhages in infective endocarditis. Quincy's sign, especially in a child who has got aortic regurgitation. They are having blanching and refilling when you press and do it, which occurs in aortic regurgitation as a peripheral AR sign. You can see that. There can be color change also in the nails, like white nails, you can get it in liver failure and in nephrotic syndrome. Pallor is seen in anemia and shock. Yellow nails is seen in jaundice. Blue nails are seen in cyanotic heart disease and exposure to cold. Green nails are seen in Pseudomonas infection. Terry's nails, that is in cirrhosis and chronic renal failure, you can see that. And usually what we call as a Murke's lines, that is hypoalbuminemia due to cirrhosis, you can see this type of nails which is there. Coming to clubbing, which is very important, that is one of the very important signs which you look, whether it's because of cyanotic hearts, whether because of the bronchiectasis, lung condition, abscess, that the clubbing of the fingers occurs. It is the bullous enlargement of the distal portion of the phalanx. So it is due to proliferation of the sublingual connective tissue. This is the sublingual connective tissue. It's in the proximal, the terminal phalanx which occurs. It is clubbed fingers, also called serpents or fingers of Hippocrates is also other name given to it. There are 4 grades of clubbing. That is, first grade is fluctuation and softening. That is, when you press it, there will be fluctuation here and softening of the nail bed. Second is obliteration of this angle. You can see this 160 angle, so obliteration occurs, it will be more than 180. It is also called as Shamroth sign. Then more and more clubbing occurs, then it will be called as parrot beak appearance. And final grade 4 is hypertrophic osteoarthropathy is seen. Coming to cyanosis, which is a very, very important sign, we need to look whether it is because of cyanotic heart disease or in shock, we need to look at it. It is bluish discoloration of the skin and mucous movement. mucous membrane. It occurs due to presence of more than 5 gram per deciliter of deoxygenated hemoglobin. That means to say that if a child has got hemoglobin less than 5, possibly you will not see cyanosis. The sites are nail beds, lips, tongue, conjunctiva, oral cavity, ear lobes can occur cyanosis. The causes: tetralogy of Fallot or Eisenmenger disease, any cyanotic heart disease, ARDS, severe pneumonia, hypoxia basically, methemoglobinemia. Then your drug dapsone, basically it also occurs because of methemoglobinemia when dapsone is given. Now you look at the palmar creases, that is, you look at the palmar crease, look for simian crease, that is one single transverse. Here you can see this transverse one line. All of us have got two lines. This child has got only one line. It is seen in Down syndrome. Kennedy's crease, that is sole crease between the first and second toe. It's again seen in this. See, you have a large toe, second toe. There is a line here. If it extends deep towards the sole, then it is called as Kennedy's crease. Sydney's line. Transverse crease often seen because both sides the transverse lines are seen here. See, if it extends beyond on the other surface, then it is called as Sydney's line. It can occur in Down syndrome and congenital rubella, it can occur. Coming to the lower limb, look at the lower limb length. Sometimes you can have limb discrepancies, wasting of the limb, gait, peripheral pulses, all this you need to check. There is what is called as genu varum deformity, or what we call as a bow leg, and genu valgum deformity. That is bow leg like a bow, and valgum deformity, that is called as a knock knee deformity. Genu varum deformity, knees are bowed outside because you get something like this. And intracondylar distance is between your knees, condyles, the distance is more. It occurs in rickets, it occurs in osteomalacia, it can occur in achondroplasia. Whereas genu-valgum deformity or knock knees, your knees comes together. Knees are closer to each other because intramalleolar distance is more than 5 centimeters, and its normal variant sometimes they get it, and it also can occur in rickets. See this pic here, you can see the genu varum deformity or a bow leg. See, the intracondylar distance is more than 10 centimeter. Here you can see the valgum deformity, that is here the knock knees occurs. Here intracondylar distance is more than 5 centimeters. This occurs in this children. So you can also look at club feet, other congenital abnormalities which can occur, that is club feet also, we call it as congenital talipes equinovarus deformity. Here you have abduction of the forefoot, inversion of the hind foot, and medial rotation and varus deformity. It is more like the equine, that is horse foot or hoof. So equinus deformity with the plantar flexion which occurs. Also you can see what is called as a rocker bottom feet. This is a rocker bottom feet which can be there, which is seen in Edwards syndrome and Patau syndrome. Like if you remember the olden days, we have a rocking chair, the base of that was a rocker bottom feet. That is what you can see, this rocker bottom, the angle which the foot is there, which called as a rocker bottom feet. Coming to the abdomen, you need to look at the shape of the abdomen, movement of abdomen, whether the abdomen is distended, whether there is scars like for example branding or operation scars, and if there is any visible veins are there, or if you can see any mass inside the stomach, all this you need to check for. And in small children, you can see what is called as an umbilical hernia. It is because of the imperfect closure of the umbilical ring. What happens is intestine protrudes outside whenever the pressure increases, like crying or straining. And most of it, as the child starts walking, as the child starts creeping, the sort of abdominal muscle gets strengthened, it closes by itself. Very rarely we need to need surgery for this, and if we do it only after the child is around 4 years. Coming to the genitalia, in males penis, you can get hypospadias. The opening of the urethra can be anywhere from the tip of the penis till the scrotum, or it could be micropenis. The normal length of a penis is around 4 centimeter at birth. We call it as a micropenis if the length of the penis is less than 2 centimeter, 2.5, less than 2.5 centimeter at birth. What are the causes of micropenis? Hypogonadotrophic hypogonadism. Basically, the hormones are less. Hypopituitarism, Klinefelter syndrome, Noonan syndrome, Kalaman syndrome. These are all different genetic syndromes which are there. Prader-Willi syndrome, a large child who is obese, mental retardation, seizures. Prader-Willi syndrome also you can get a micropenis. How do you test the testis? Because what is a normal volume? You don't calculate in size, you calculate as volume. Testicular volume is measured by instrument what is called as a orchidometer. So, or through the ultrasound. So, low testicular volume which occurs in testicular atrophy, high testicular volume if there is any testicular tumors, normal volume is about 1 centimeter cube before the puberty which occurs. Here you can see this different volumes which are there, from 1 to 25 different volumes are there. This is how we check it. Coming to females, look for any discharge from the external genitalia, bleeding, or if there is any ambiguous genitalia. Hydroxylase deficiency, you can get ambiguous hermaphroditism. All this you can get ambiguous genitalia. Look for the discharge, whitish discharge, bleeding which is there, which is common in neonatal period. You need to sort of reassure the parents because of that. Look at the anal opening in a small child. You can have what is called as an anal atresia. Anal opening is missing. So, orifice counting will be done in birth. Suspect anal atresia if the mother gives a history of non-passage of meconium. Usually, as you know, meconium is passed within first 24 hours. If it is passed below that, it's very important we double check the anal. There are 4 different types of anal atresia depending upon where it opens, how high is the deformity which occurs in the thing. Coming to the skin, that is very important for us to know what are the different types of skin lesion. That is macules. It's a flat, palpable, hyper or hyperpigmented lesion on the surface of the skin. Papules, these are the ones palpable elevated lesions which is less than 5 millimeters. Larger ones are called nodules and still larger ones are called tumors. Plaques, it's a confluent of plaques, papules. It's a plaques. It's a confluent of papules is called as plaques. Vesicle, elevated small fluid filled blisters which is less than 0.5 centimeters. Pustules, superficial vesicles that contains pus. These are the vesicles which contain pus. Wheal, it is slightly elevated lesion in the skin with the central portion which is paler than the periphery, because central portion is paler than the periphery. Which pedicule, it's a pinhead size bleed of macule which is less than 2 millimeters. Purpura, large petechiae which does not blanch on pressure, which is between 2 to 5 millimeters. Ecchymosis, it's a large excavation, ecchymosis, large extravasation of the blood in the skin which is more than 1 centimeter. Sometimes you can see some abnormal skin lesions over the body which can be a pointer for some sort of a disease which the child may be having. One of them is what is called as a Kefiole spot. These are coffee colored areas on the skin. That means like milk. If you add coffee, how it looks, the similar color, what is called as Kefiole in French, is used. It is significant in the prepubertal area if it is more than 5 millimeter in size and more than 6 in number. Postpubertal area, more than 15 millimeters in size and more than 6 in number. Any spot at the center of the body, this fellow has got center of the body, isolated spot more than 15 millimeter in size, and lesion also along with neurofibromatosis it is there, it is quite significant. This again what we see in a small children less than 2-3 years, you see more common in the newborn period. Parents are little worried. These are called as mongoloid blue spots. There are grey blue pigmented macules over the lumbosacral area. It may be found in the buttocks, thighs and the back, and it is benign and fades over the time. It is more in pigmented skin rays, Down syndrome and gangliosidosis, because it is because of the migration defect of melanocytes you get this, but it's a benign, it just goes off. Then here you can see what is called as a molluscum contagiosa. Many of them you would have seen. It's a light brown multiple raised lesions seen in clusters. It is because of viral etiology, it is caused by the virus. It is because of the direct contact a patient has with the other person, it resolves spontaneously between about 6 to 9 months, and if you want to take it off, you can do a curettage or chemical cauterization in these children to get rid of it. Then you can see many cases which comes with hemangiomas. Those are what is called as the salmon patches. It is pale pink macule at the nape of the neck. You can see at the eyelids, on the top of the eyelids, face, and it is present of this thing. Sometimes you call it as a stroke bite also. Over the eyelids you can see that. Port wine stain, it is present at birth, may fade with age, but never disappears. It is usually seen with Strauch-Weber syndrome, Klippel-Trenaunay syndrome. These are a different type of syndromes which is there, genetic, there you need to do that. Then you can get little larger. These are called as strawberry nevus, that is raised, bright red, compressible strawberry-like lesions. It appears after birth. It increases in size, then slowly by the end of about 7 years, elulate. And only problem is when it occurs, it can bleed when there is trauma to that and can cause secondary infection and complication. Occasionally you get what is called as a cavernous hemangioma. It's a large area located deeper, bluish red mark. 90% of it disappears by about 9 months. Then you have a large one, because when there is a hemangioma, large hemangioma, please look at other areas where this hemangioma can occur. Sometimes it can occur in the liver, which is called as a Kasabak-Merritt syndrome, a large deep-seated cavernous hemangioma associated with platelet sequestration. What happens is when the blood goes through that, the platelet in the blood gets sequestrated there, which causes sequestration, and thrombocytopenia and hemangioma. Hemorrhage can occur in this child. Here you can see this cavernous hemangioma on the cheek. Here on the cheek you can see this is how it looks now. It's very important, though this is barbaric custom of branding has almost disappeared, but many places it is still there. We do see some of the children who are branded and brought to the hospital. Branding is an inhuman traditional practice, most commonly employed to treat various disorders in neonates and children in certain communities of India. Though stringent law exists to prevent such harmful practices, case of branding is not uncommon in the current area. So it is very important that we need to sort of educate the parents from the rural area against this branding. It's a very inhuman type of treatment or custom what we have this thing. So students, we have gone through thoroughly general physical examination. We have from the scalp, head, eyes, chest, limbs, all these parts we have gone through that, because it's very important for us to look carefully. Smallest thing can be the clue for the final diagnosis. Don't miss. Look, make it to a ritual to examine every child, every part, every surface, everywhere. So you need to go through this as a ritual so that you won't miss it. You will be able to come to a final diagnosis. Thank you. Thank you so much.